Welcome and thank you for taking the time to enhance your skill set. In this short video, we'll explore the dynamics of domestic violence and the essential role healthcare professionals play in recognizing and responding to it. As a provider, you may be one of the few trusted people a survivor interacts with, someone who can recognize the subtle signs and offer safe, compassionate support. Begin by grounding ourselves in what domestic violence is and how it shows up in clinical settings and what you can do to make a difference. It's important to distinguish between a toxic relationship and an abusive one. Toxic relationships can be harmful, but they typically involve conflict between people with relatively equal power. In this type of relationship, either person could leave safely. Domestic violence is different. It's a pattern of intentional harm where one person holds power over the other. They use this power to create fear, control, and cause harm. It isn't just physical assault. Survivors may experience manipulation, financial control, or reproductive coercion. Being aware of these patterns is essential in your clinical interactions. The power and control will developed by domestic abuse intervention programs in Duluth, Minnesota, illustrates the range of tactics perpetrators may use to maintain power and control in a relationship. While physical violence and threats are often the most visible, many survivors experience subtle, ongoing behaviors like emotional manipulation and gaslighting, isolation from support, or financial control that are just as harmful. These tactics are deliberate and serve to instill fear, break down autonomy, and maintain dominance. Understanding this model can help you recognize the less visible signs of abuse in clinical settings, hear better when abuse is being described, and then respond with empathy and awareness. Domestic violence impacts people across every identity and community, but its impacts are not equally distributed. Indigenous, Black, LGBTQ, disabled, and rural populations face higher rates and systemic barriers to care. 1 in 4 women, 1 in 10 men, and 55% of transgender individuals experience intimate partner violence. Indigenous women face the highest rates of interpersonal violence among all racial and ethnic groups, and people with disabilities are more than twice as likely to experience domestic violence than individuals without disabilities. Systemic barriers like racism, ableism, homophobia, and rural isolation can increase both the risk of abuse and the difficulty of accessing support. That's why it's essential to tailor your approach to each patient's lived experiences and unique needs. When you understand how identity intersects with abuse, you can better provide care that is equitable, trauma informed, and survivor centered. Survivors make thoughtful, often complex decisions about when and if they disclose abuse. Their silence isn't a lack of trust, it's often a protective response. They may fear being judged, not believed, or blamed. They may worry about losing their children, facing legal consequences, or making their situation more dangerous. Some have had negative experiences with systems in the past and are unsure whether support will truly help. As a healthcare provider, your role isn't to force disclosure. Instead, focus on building trust, creating a safe and respectful environment, and responding with empathy, regardless of what a patient chooses to share. Even if a survivor never says the words, your compassion and care can still make a lasting difference. You may have heard domestic violence described as a cycle, with phrases like tension building, an explosive incident, and a honeymoon or apology phase. But in reality, abuse doesn't always follow a predictable pattern. Domestic violence is a pattern of power and control, not a predictable step by step process of repeated events. People who cause harm use a wide range of tactics emotional, physical, financial, or psychological whenever it serves their goals. The behaviors may shift or escalate, but they're intentional and strategic. For example, when an abuser gets angry, they might use different tactics to make the survivor aware of their anger, but these tactics don't follow a set cycle. Often, only the survivor understands the signals. Abuse in healthcare settings is often subtle and easy to overlook. You might notice missed appointments, frequent cancellations, vague or inconsistent explanations for injuries, delayed prenatal care, or a partner who insists on answering questions and staying in the exam room. Survivors may also present with chronic pain, anxiety, or other health concerns that don't have a clear medical cause. Pay attention to patterns over time and listen closely, not just to what's said, but also to what is left unsaid. Your intuition, paired with compassionate observation, can be a powerful tool. Even when there's no disclosure, your awareness and care can create a safer space for patients to return to. Your presence and approach can make a lasting difference. A trauma informed response means recognizing that every survivor's experience is unique and respecting their autonomy at every step is critical. Avoid assumptions, ask permission before beginning procedures, and offer choices whenever possible. Create private, judgment free spaces where patients feel safe, seen, and heard. Use clear, compassionate language and don't expect full disclosure. Affirm that a survivor's responses are valid, even if they seem small or hard to understand. Healing begins when patients feel they have control, dignity, and support in their care. Every member of the care team can help create safety through simple, intentional actions. Pair universal education about domestic violence with your clinical questions. Universal education means offering all patients brief, supportive information about healthy relationships, resources, and safety, whether abuse is disclosed or not. This normalizes the conversation, reduces stigma, and opens the door for future help seeking. Doctors and nurses can pair supportive education with behavior based questions. Try asking, I ask all my patients this because we know relationships impact health. Has anyone ever tried to control your appointments or medications? I also want to give you this information card, or in case you or someone you know ever needs support. Medical assistants can offer handouts or resource cards during intake or vitals, framing it as routine. You can say, we share these with everyone. It has info on healthy relationships and community resources. Triage nurses can ensure private intake when possible and normalize conversations. You may say something like, some of the questions I'll ask are about safety and relationships. We ask everyone because it's part of whole person care. Doulas and birth support staff can use moments of connection to gently share resources and affirm autonomy. You may say, we want all birthing people to feel supported and informed. This info includes help if you or someone close to you ever needs it. Each role offers a moment to build compassion, trust, and feelings of safety. A simple shift in language or an offer of privacy can profoundly change how a survivor experiences your care. Dynamics of domestic violence are complex, but your response doesn't have to be. When survivors feel safe, respected, and seen, they're more likely to return for care, share their experiences, have better maternal health outcomes, and begin to heal. Your role isn't to fix or diagnose the abuse or to save the person from experiencing it. It's to create a space where healing is possible. Through trauma informed care and universal education, you offer more than treatment, you offer dignity, choice, and connection. The Michigan Coalition to End Domestic and Sexual Violence hotline for domestic violence is 1-855 Voices 4. Thank you for taking the time to watch this short video on the dynamics of domestic and sexual violence and for showing up with intention and compassion. You can learn more about this and related topics at www.mcedsv.org. Click on the maternal health heading to access a wide variety of other recorded trainings, information on upcoming live trainings, customizable tools, and hundreds of other resources. This video was developed with support from a grant from the Michigan Department of Health and Human Services Maternal Mortality Surveillance Program. The opinions, findings, and conclusions or recommendations expressed in this publication program exhibition are those of the authors and do not necessarily reflect the view of the U.S. Department of Justice or the Michigan Department of Health and Human Services.